Hello and welcome to April's Continuing Education for Shreveport Fire Department. We're going to talk about the identification and management of sepsis in the pre-hospital environment. So some of the objectives we're going to cover are the different forms of sepsis, understanding what sepsis is on a pathology point of view, and then how sepsis has changed over time and what we're currently at, even though the current regimen for sepsis is changing as we speak. They reevaluate it every couple of years. Understanding the key elements of how to manage sepsis and what we do in EMS to identify and how we appropriately initiate treatment better sometimes than just someone coming into the hospital. So finally, as a sepsis protocol, understanding how our protocols can interact with furthering our own intent of improving patient care. So first off, we need to identify what sepsis is. It's going to be when the immune system becomes overactive to an infection. It's going to cause inflammation, it's going to affect how well other tissue and organs work, and eventually those tissues and organs will not work anymore and the patient will die. This is a very time-sensitive issue. This is just as important as a heart attack or a stroke, and when sepsis is recognized early, people can be given the right treatment right away. However, if we don't recognize the signs and symptoms of sepsis, because they can be subtle and they can vary from person to person, it can also lead into morbidity and mortality for our patient populations. So how do you define sepsis? Well, this has been an ongoing issue. We have many different calculators. I'm sure some of you remember the SOFA, the Sears, the Q-SOFA. We have the Apache. There's a lot of different ways we can make this a thing, and we have a lot of different labs and a lot of different vital signs that we use in each one of these calculators. So really understanding that sepsis is a syndrome, and it's a group of body dysfunctions that pertain to different organ systems, and as we'll see in later slides, what does that mean for each organ system? And as these dysfunctions continue to progress, they can either be in a predictable way, which means that they just stop working, or in an unpredictable way where other organs will affect other organs' functions. So sepsis does have a very high mortality rate, and it, like we mentioned before, can present variously with different people. So this is the reason why the End Sepsis campaign has become so important, both in the hospital and in the pre-hospital setting. And you even have some services in EMS starting antibiotics before blood cultures were drawn, starting goal-directed therapy with fluid management, starting blood draws so that we can get the process done quicker, because just like we say with heart attacks, tissue is time, and this is the same concept. The longer that we wait, the longer we delay antibiotics and fluids, the less likely we're going to be able to get this patient back to their normal functioning that they were before they were ill. So just a couple of people that have died. Christopher Reeve, the Superman back in the day, he passed away from sepsis. He had I believe it was urosepsis or a wound infection that then just progressed. Some of the really important and famous people throughout time have died through sepsis, and it can be your best friend, it can be your neighbor, it can be the patient that you get in your next call. So we need to make sure that we understand the subtleties and varying presentations of sepsis so that we can initiate the life-saving treatment early on. So what is sepsis mortality? Well, severe sepsis and sepsis are different. Just like there's 3 different types of sepsis, which we'll talk about in a later slide, but there's regular sepsis, which is you meet some qualifications, we're kind of like the early edge of it. And then we have severe sepsis, where the patient's met a lot of criteria, they're not quite hypotensive, but they're very ill. And then septic shock, which would be the epitome of severe sepsis. And as you can see right here, a AAA, which is something we're really afraid of, and that's why we want to make sure if you have a throbbing pulsating mass in your abdomen, that's probably going to be, even if you make it to the table, you may not survive because of the sequelae that comes after surgery. But severe sepsis itself almost covers a 40 to 50% chance of death. Now, looking here at a STEMI, with all of our interventions and whatnot, that's like less than 10%. Strokes, less than 10%. Now, granted, the morbidity may be low, the mortality may be low, but the morbidity can be high on these as well. But just seeing how quickly one could die from sepsis should really make the hairs in the back of your neck stand up when it comes to these ill patients. So what is the sepsis spectrum? So as we progress through our mortality spectrum here, you can see here that when you start with a blood pressure that is normal, but the heart rate's a little high, they're a little tachypnic, they may have a high fever or a low fever, and we'll talk about why that's important in a minute. Abnormal white blood cell count, which we don't have access to in the pre-hospital setting unless you have an ISTAT, which we don't. And then low PCO2, which we can kind of get a bearing of that when it comes to our end-tidal CO2 and our capnography. So this is a really important tool. One could say, well, why are you giving this septic patient that's not really requiring oxygen on capno? And this is one pearl that I really want you to get out of this lecture series here, is that why our capnography is very important with sepsis patients. So if you have 2 Sears criteria plus an obvious infection, their urine looks like chunky potatoes, they're having, purulent diarrhea, a wound looks very nasty, hot, erythematous, it's got purulence coming out of it, or they're having a really junky cough, really bad fever, and they're a neutropenic patient or a sickle patient, we know these patients are probably just a knock away from opening the door to sepsis, and that being said, severe sepsis. So what is severe sepsis and septic shock? Okay, so you'll notice I made that distinction on a previous slide. So severe sepsis is sepsis with end organ damage or hypotension or an elevated lactate. And we can see an elevated lactate in the pre-hospital setting, and I'll show you how to do that in a couple slides. Obviously, we can't draw blood. We don't have a ISTAT that we can look at the lactate, but we can use the tools that we have in our toolkit to determine if this is going to be a positive finding or not. Now, septic shock is the end result here. This carries a mortality of 50% or more. This is severe sepsis and then persistent signs of end organ dysfunction. What that means is that if you have a patient that you notice that they're sick, they've met Sears criteria, they're hypotensive, you give them fluids, and what does fluids mean? Well, it's the 20 to 30 cc's per kilogram. Now, I don't know about you, but I've never been on a scene long enough to be able to give 20 to 30 cc's per kilogram of a patient. That's usually taken care of the hospital. So the persistent end organ damage is kind of what we would see. You give them some fluids, you try to perk them up, or if we had the capability like Levofed on the ambulance, we get their blood pressure corrected, but they're still not acting right, then that would be considered to be septic shock. So we are usually going to see the spectrum of patients in between the serious to severe sepsis, and then the septic shock patients are going to be the ones that we officially diagnose in the hospital setting. So what is this progression and what is the mortality? This is a very slippery slope, okay? And the reason for that is because it can progress slowly in some patients depending on the infection, or it can become very rapid. Especially with your immunocompromised patients, we have a lot of sicklers, we have a lot of diabetics, we have a lot of HIV positive AIDS patients in our parish. And so knowing that and I just mentioned those specific patient classes because those are your immunocompromised patients. If you didn't know, when a patient has diabetes, they are by definition immunocompromised. It's a very interesting aspect to think about because we see so many diabetics, but knowing that and then putting the pieces together and thinking that our diabetic population, they're more prone to wound infections. We have to do annual foot exams on them whenever they come into primary care. They have to have, every quarter have labs drawn until they're stable. And the reason why we do that and that we keep such close eye on them is because they're just as susceptible to infections as, say, for example, someone who has not white blood cells because they've been wiped out with chemo. Now, it may not be that bad, but in the long run, they do have an increased morbidity and mortality as compared to those patients. So knowing that you can have a high risk of suspicion that things can go very badly very quickly with our immunocompromised patients just by asking them their past medical history and keeping in mind, oh man, I need to convey this to the nurse. I need to convey this to the doctor when I give report. Your voice is very important. Your voice is very important whenever you're the one who saw the patient at the scene. Most of the people in the hospital have never been on an ambulance. Most of the people in the hospital have never been in someone else's home, i.e. a patient's home, and seen them at their worst, like we do in EMS. Making sure that you convey those important little points to raise the index of suspicion for the provider so that they can provide the timely care that's necessary. So we've already talked about this progression here, and you'll see severe sepsis and septic shock. This uses hypotension over on septic shock, and then it kind of removes it from severe. But I hope you understand the nuances. It's persistence in septic shock. Now, what are we talking about with organ failure? And we'll look at this in the next slide here. But when you have someone who's altered, or they're not putting out urine, or they're having chest pain, or they're having shortness of breath, those are all signs of organ failures, all from different organ systems. But as you notice right here, one organ that's affected, it carries a 20% mortality. And this is like 30, 60, 90 days. 2 organs, still 20 to 30%. 3 organs, oh man, we go all the way up to like 60 to 70%. That's a big jump. 4, 5, if you're at 5, this patient's an ICU patient, they may not survive the ambulance ride, but they almost have 100% mortality. That's crazy. When you think about all these things, and you'll see on that slide about you can cherry pick what these patients have based on what their presentations are, and you can automatically think, man, I have an end organ damage, and now they have 4 organ systems. Man, that's a 60% mortality. That's a lights and sirens right there, if you don't mind me saying. So let's talk a little about physiology real quick. What happens when you get an infection? Local infections usually have nonspecific inflammatory responses. There's redness, there's pain, there's heat, and then you also have the individual cells that come in there, and that corresponds with the 3 phases. There's the vasodilation, increasing the blood flow in order to get the B, T, and white blood cells in there to fight the infection so it doesn't spread. Then the vessels themselves will start to open up a little bit, the walls will start to expand, so that you can have those cells exiting the bloodstream and entering into that infected tissue to provide the appropriate action to the infection. And then once infection is done, the tissue starts to repair itself. If you have a wound, it starts to scar over. If it's internal, it can either form a ring of calcification around it, and that's in case you have an embedded body that won't be able to get out. And so usually everything's okay. There's no problems. There's no systemic symptoms, fever, chills, malaise, shortness of breath, pallor. It's localized to that area. So what happens in sepsis? Well, the fundamental concept that you need to keep in mind whenever you think about sepsis is hemostasis. Remember, this is the body trying to keep itself normal. This is the healthy balance of blood coagulation versus anticoagulation. And so I want you to think about that example for a minute, right? In times when the patient's normally healthy, our bodies are going to produce clotting factors in the blood that are always going to be on standby to clot whenever necessary. Now, these factors are going to be activated when the lining of the organs and blood vessels is disturbed or traumatized. And these clotting factors are essentially like a reservoir of highly unstable gunpowder. Once they're activated, it sets off a chain reaction of clotting there, and then it starts to spread the signaling molecules out to the rest of the body. Now, when those signaling molecules are found by a tissue that's not injured, then this then activates the negative feedback. So this is the check and balance system of the body in order to make sure that the body doesn't be overwhelmed by this hypercoagulation. So let's bring it back to sepsis for a minute. In sepsis, the infecting organisms can cause direct trauma to the endothelium and the body, but it also suppresses or depletes the supply of available anticoagulating factors. So a perfect storm of intravascular coagulation occurs everywhere in the body. Now, that being said, this is most notable in the microvascular system, and this is going to be in our organs, the very smallest capillaries that are responsible for the exchange of waste and nutrients in order to keep the normal functions of the body running. So this then will lead to hyperperfusion, and then you'll find the examples of end organ injury. The endothelium, or the lining of the organs and tissues, then continues to malfunction, resulting in blood vessel wall motor tone decrease, which then will lead to hypotension, leaky blood vessels, edema in the lungs, brain, and soft tissues, and then death. So it's an uncontrolled, exaggerated immune response. The body is trying its best to maintain itself, but once the damage occurs and it's this positive feedback loop, it's never ending over and over and over and over again, eventually the body will just wear out and stop. So our point is that we have to fight the infection with antibiotics, and that's usually done in the hospital setting. And because of these leaky capillaries and this hypotension, we have to fight that low blood pressure that's causing low pressure to the endothelium by giving them fluids. And that's the reason why fluids are also just as important during those first 3 hours, and really that first golden hour when it comes to sepsis. So let's talk about SIRS versus sepsis. So number one, sepsis, as you can see here on the left of the screen, is going to be multiple causes of infection: fungus, parasites, viruses, bacteria, other. All right. Now, if you go to the right, with SIRS, or the systemic immune response, is going to be caused by multiple things: trauma, burns, and pancreatitis, inflammation. And so once you identify the SIRS, then you must also look for the trigger. Infection from a type of germ like a bacteria, virus, or fungi is possible, but as you can see here, there are other conditions than infections that can result in the SIRS response. So this is the reason why whenever SIRS came out, everyone started like really think about like, oh, it's a great thing, man, we can really screen for sepsis and whatnot. But then it became an issue because then people started to say, well, I cut my toe, I can be SIRS positive. And they're right. And so you really have to be a detective when a patient comes in, and you have to have that clinical, belly feeling. You feel it in your belly like this patient's sick. And that's a really important aspect to have with sick and not sick. So if someone comes in and they're tachycardic, tachypnic, and they have a white count, well, they broke their leg, well, they're not acutely infected. They could be, but they had a more immediate cause. Now, if they're a nursing home patient and they're tachycardic, tachypnic, and they have a white count, well, we probably are on this side of the fence on the left. That's where your clinical context and decision making comes into play. So let's take a pit stop at SIRS for a minute. This is going to be the one that we're most familiar with, I guess, because it's the oldest one that we're familiar with in the pre-hospital setting. I'm sure there are other ones. This is one personally, anecdotally, I'm more familiar with because when I was in EMS and on the truck, we used SIRS all the time, and that was our go-to. So it's a constellation of associated abnormal vital signs that aren't really specific for any one disease, and 60% of all emergency department patients meet SIRS criteria, but they don't all have infection, thankfully. And as a good rule of thumb, if your patient meets the SIRS criteria for any reason, then you need to really think that, is this something going on that I need to be concerned about? That should be the first step, the pass-through, so to speak. So if you go on a call and they're diabetic and they're tachycardic, tachypnic, and you look into it like, what are you thinking about? You think they have sepsis? No, you may think that they have DKA, or they can be hypoglycemic. So these are things that we think of naturally, but now we're putting a name to it. So using the SIRS as like a good test that is this patient well or not well is a good way of using it. Now, SIRS technically includes the results of a blood work, like the white blood cells. And so adapting SIRS for EMS doesn't necessarily mean you use white blood cells, it uses glucose and mental status. And so then people started to get it changed and whatnot. And so in ESO, there's other calculators like QSOFA that are have a different sensitivity and specificity than SIRS do. So what are the risk factors? There are a lot of them. Extremes of age, very old, very young, people who are not going to be able to take care of themselves, not cleaning themselves, someone who's not able to move, recent surgery, procedures, illnesses, childbirth, any type of termination, or you could have retained products of conception or miscarriage, reduced immunity, diabetes. You could have that with HIV/AIDS, cancer patients. Diabetes, like I said, I'll keep on telling you over and over again, diabetes increases your risk for infections, as we all know. Liver cirrhosis are really rotund abdomen, hepatitis C patients, and then our lupus patients and rheumatoid arthritis patients. And you could have that just by the fact that they have the disease, but also because of the medications they're on. They're on immunosuppressant medications like methotrexate or cyclosporin or things like that. HIV/AIDS, that's understood. And sickle cell disease patients, it's because they're chronically in a state of inflammation as those sickled blood cells start to rip into the endothelium. Splenectomy patients, you might ask yourself, why is this? Well, as we recall from our physiology and anatomy days, our spleen is a good reservoir of white blood cells, and it helps to get rid of encapsulated bacteria. And if you do not have that, you lose a big chunk of your immune system. Then compromised skin, burn patients really are an important part here. Chronic wounds, again going back to diabetes, and then ulcers that are just open to the world and they may not be taken care of appropriately. So chemotherapy, cancer, post-organ transplant, because they're also on immunosuppressants. Chronic steroid use, immunosuppressant. Recent antibiotic use because you've cleared out the regular flora of the body. And then indwelling catheters of any kind, dialysis, Foley, IV, PICC, PEG, whatnot. And that makes sense. I mean, you have an open venue to the world outside. No matter how much you clean that tube, they've been studies that show every week that a person has a Foley catheter is in the 5% risk of infection. And so you might ask yourself, well, what happens if they coat it with some type of antibacterial? It doesn't matter. They've done studies on that as well. So long as you have a line in you, you have an increased risk of infection. Every week is more risk of infection. So do you know the signs of sepsis? Well, I mean, we all do. It's fever or very cold, tachypnea, extreme pain or physical discomfort if they're pale, disoriented, confused, difficult to wake, elevated heart rate. But the patient often doesn't appear acutely ill at the beginning. They're compensating. And so after the compensation ends, well, they end, and we're in serious trouble. So looking at the multiple organ system dysfunction. Now, what I really want you to take out of this slide is most of the stuff you already know. And most of the stuff you think of like, oh yeah, that's a part of this. But remember, we go back to that graph. Every part, every system that is affected increases the risk of mortality. So sepsis is going to occur when the inflammatory process of the body is responding to the infection, and it's then going to exceed the boundaries of that local environment, that cut on the finger, that cut on the arm, or whatever. The immune response becomes more global, more generalized, and then becomes uncontrolled, unregulated, and then it starts to just domino itself and won't end. This will then cause widespread injury. The cells are unable to perform their functions, leading to organ dysfunction, and then low blood flow results because of the mismatch in the oxygen that's available to the tissue's oxygen needs, which are over exceeding that of the oxygen delivery to that site. What's the body going to do? Well, the body's going to secrete those fight or flight hormones, epinephrine, norepinephrine. It's going to produce lactic acid as it uses that epinephrine to jumpstart the energy production and thereby generating that lactate that everyone talks about. Mortality is very high in patients that have elevated lactates. Now, most of the time when a patient comes in, for example, with a trauma patient, you can have a lactate of 2 or 3. Or an aggressive psychiatric patient, you can have a lactate or a CK value elevated. You treat them with fluids and they'll be fine. But when we're talking about elevated lactate in our patients that come to the ICU, you're talking about people that have lactates in the 8, 9, 10, 11, 12, and the higher the number, the less likely we're going to be able to get them back. Those are the people that unfortunately will not live on this plane for very much longer. So there are different criteria of what constitutes end organ compromise or organ dysfunction, and so these criteria are used in many ways when trying to treat the sepsis and identifying the severity and how well it's going to progress. Like we said, every organ system is more mortality. So for example, in our central nervous system, we have altered mental status. If they're GCS of 14, that's altered mental status. If they're tachycardic or hypotensive, we know that already. Tachypnic or hypoxic, okay. If they're not making urine, that's a way we can test to see if their urinary system is working, their renal system. So you just ask, when's the last time you went to the restroom? Number 1 and number 2. That's a simple question. Just like we learned back last month with our pediatric resuscitation, how many diapers is that baby going through? Hepatic, are they yellow? Do they have some type of coagulopathy? Or by the mere fact, do they have ascites? Are they a hepatic patient? Period. That's a check mark. Metabolic, lactic acidosis. Well, we can't run labs, but I'll teach you a trick in just a minute. And then petechia or purpura. If you notice that they have this like red or purple rash all over their legs or arms, then that's going to be a problem, and that's another system. So let's just present a patient here for a moment. You have a 45-year-old male that's in the nursing home, status post, broken leg. He had to have a rod put in. He had to go to the LTAC. The LTAC calls you because they said that he's not acting himself. And when you get there, his heart rate's 140, he's breathing about 28 times a minute, he's 91% on room air, and they said that his Foley has not put out any urine. Well, that is altered mental status, cardiovascular with tachycardia, he's tachypnic and mildly hypoxic, because remember, someone who does not have COPD, anything less than 94% would now be considered a hypoxia, although mild to moderate, it still is low. And then he's not putting out, you have 4 of these systems that are affected, and as you recall from that previous graph, that's roughly a 40 to 60% chance of morbidity without action. So, what are the causes? We know this: pneumonia, UTIs, infections after surgeries, skin infections, C. diff, and that's usually because of antibiotics that we've given the patient, or IV drugs, bacteremia. And so what do we do about it? Well, there's been a lot of research about it. Man, so many grants, millions of dollars, because it is such a impactful diagnosis, and it is so easy to be very proactive right at the beginning. You know, like I said, in your minds, sepsis should be just as important as STEMIs or strokes. And we harp on scene times and making sure that you get them their treatments in a timely fashion. The same can be said about this. So at many hospitals, administrative leaders are educating everyone that comes in contact with a patient, doctors, nurses, EMTs, and they're using posters and videos, placards. If you come to LSU, you'll be able to see like the Surviving Sepsis campaign, and there's a big old line graph that says, how many patients have we seen and then initiated goal-directed therapy within an hour? And the line keeps on going up because we are very attentive to it. We have Sepsis Alert teams, and we do that at LSU. If you are concerned that this patient is sepsis, you let the pharmacist know, because the pharmacist has to release those medications very quickly. They'll bump it to the top of the queue. And so we also have people, all hands on deck, starting IVs, getting that fluids in, starting those antibiotics. And then we also have our quality management team maintaining compliance with the care bundles, which is the sepsis bundle, which includes fluids, antibiotics, and referrals. So what do we do, and what can we do? Well, in ESO, you know, we have a Sepsis Alert button. That's when you call report. You know, if you identify the patient as sepsis, we have a QSOFA form that we should be using. You know, these are all tools that help us communicate to the next level of care that we did what we did for a reason, and we did the right thing for the patient. So in the future, when you start seeing these sepsis patients and we start rolling out things to try and improve our sepsis response, we're going to use this as our quality improvement in order to make sure that our patients are being treated as if they were being treated in the hospital. And I'll tell you why that's important in a couple slides. So early identification of sepsis is important because the time it takes to administer the correct antibiotics is one of the most important factors, as well as fluids. Every hour that antibiotics is delayed increases your mortality by roughly 8 to 10%. And as we can see right here, patient survival when they come here may be 80% depending on a 1 to 2 organ failure, and then we have a slow and steady decline to the point where the patient will die if they are septic for more than a day and a half. So the whole principle behind emergency medical services is being able to identify and treat life and limb-threatening disease and injury. This is fundamental because before EMS, it was you throw them in the back of the car and just get them to wherever they needed to go. And back then, we also didn't have emergency room doctors. It was either an internal medicine doctor or a family medicine doctor working in the emergency department. They didn't really have formal training. It's just they knew that if a patient was sick, we should start things. So EMS has a demonstrated benefit in STEMIs, strokes, and trauma. And it's the same thing in sepsis. EMS has clear and cut benefit to patients by our early recognition and our early management. Over the past 20 years, we learned that we can improve survival from sepsis when you identify it correctly and right away. This provides the need to provide the reverse for organ hypoperfusion with IV fluids and other drugs that can reverse shock, and providing antibiotics as quickly as possible. EMS is a very important role in helping hospital staff achieve the goals in order to, at the very end, decrease morbidity and mortality from this life-threatening disease. So let's talk about some research here. So there was a journal article written in 2009 by the the Journal of Emergency Medicine, and it found that in time-critical conditions like strokes or heart attacks, pre-hospital providers make a significant difference to mortality. That was really the start. We kind of knew it, but no one had really done a study on it, which started to really kick up. We started to have these gunners, like at the Eagles conference, saying, oh yeah, we're going to do STEMI protocols, we're going to do stroke protocols, blah, blah, blah. And then as the smaller systems started to get equated to that, we started to become more aggressive with it. So in this study, this was done, and it evaluated 253 patients that were diagnosed with sepsis once they arrived at the hospital. And about 131 of them were transported by EMS. So the mortality rate of the total people that were brought was 21%. EMS staff recognized only 13.7% of the transported patients with severe sepsis or septic shock. In 52% of these, or 52 cases, or roughly 40%, sepsis went completely unrecognized. And this may have been due to an incomplete primary survey, but as we all know, primary survey is A, B, C, D, E, and trauma, and then A, B, C, D, and then sample. So that indicates to me that either they were just load and go or something happened. And then in the other 60 cases, 45.8% or roughly 46% sepsis went completely unrecognized, although the SIRS criteria was present on their documentation. So this study showed that the recognition of sepsis by EMS is low, and that was because of lack of awareness of the syndrome and infrequent measurement of temperature and respiratory rates. So that's something that we need to be more conscientious of. Getting an accurate respiratory rate, it doesn't mean you have to stop everything you're doing, but you know as well as I do that you can see if someone's breathing quickly. But taking a moment's notice just to stop and say, I need to evaluate this respiratory rate appropriately. And then getting a temperature. Getting a temperature is paramount. And if you can't get a temperature by the mouth or the arm, you should be getting it centrally in the rectum. And not many people want to do that. You know, it's like it's a violation, but we're talking about life and death. I mean, if this patient is an old patient and their mouth has just been open for 4 hours, do you really think that we're going to get a good PO temperature? Probably not. And if the temperature cannot read because the patient is so cold and clammy, then they're probably hypothermic and they're probably really sick. So you should probably get a rectal temperature. So understanding that a core temp, when it's serious enough to warrant your spidey senses that something's going on, that is really the definition of what you should be doing to provide adequate care for these patients. So let's look at this right here. Pre-hospital intravenous access and fluid resuscitation showed that of the 1,350 patients that met criteria for severe sepsis, administration of pre-hospital fluid decreased hospital mortality. Starting fluids early is important. This study looked at opportunities for EMS in care of sepsis. This was done, I believe, I don't remember what it was, but it was a study that showed that of all sepsis patients, the ones that were brought in by the ambulance were more likely to be old from a nursing home, have abnormal vital signs, elevated lactate, and organ dysfunction. And the purpose of this was to say that EMS sees sick patients, and we care for the sickest sepsis patients because obviously they're not able to drive themselves to the emergency department. And so the mortality was higher for EMS patients than non-EMS patients. This study was the impact of EMS on emergency department care of severe sepsis, and what this showed was that it compared severe sepsis patient arrived by EMS to those that did not. And what it showed is that there was a 35-minute reduction in initiating of antibiotics because you've already done the primary survey, you've already given a report, and most likely you're going to be roomed. And then there was a 41-minute reduction to targeted sepsis resuscitation, which, as you recall, is how we help and heal these patients. So let's talk about the elephant in the room, and this is going to be early detection and treatment of patients with severe sepsis by EMS. And so multiple studies have demonstrated a benefit if we train ourselves to detect and initiate early treatment. And it's a proven fact that if you are a competent provider that can identify this and implement the appropriate treatment in a timely fashion, you will save someone's life. So what are the roles? And we do have significant roles in this. We decrease the time to IV fluids, decrease the time to antibiotics, decrease mortality, and eventually a shorter hospital stay and a greater increase of return to baseline before the patient got ill. So how do you identify the sepsis patient? You're going to look for and ask about infections. You need to look at all the skin. You need to look for and ask about risk factors. You need to check your temperature accurately. And so understanding that what you can visually inspect is just as important as what you can elicit from the patient with asking your sample questions, and then also your temperature. Your temperature is key, okay? Temperature is considered to be a fever of 100.4 or above. Now, if they are less than 96 degrees, then that is more dangerous. The body is not meant to be cold, and the body's responses to infection is to be hot. So if you can imagine, if they are hypothermic, then they may have been decompensated. So looking for your SIRS criteria and the vital signs, looking if the patient is in shock, either from your vital signs or just by your visual inspection. They have tanting of the skin, low urine output, they don't look well, they don't pass the eyeball test. And then looking at your end-tidal CO2. Why is that important? Well, with your end-tidal CO2, it kind of goes along with your airway and breathing. So making sure that they're not, hypocapnic or hypercapnic for retention or blowing off, and then making sure you get their saturations above 92%. Like I mentioned before, the true definition of hypoxia for a non-COPD patient is less than 92%. You can get them up with a non-breather mask, CPAP, doing an invasive airway, and then making sure that you're addressing their circulatory needs by getting a large bore IV. A 24 gauge in the hand is not going to cut it. If you need to drill, you should drill. And the reason for this is that this is a life-threatening emergency. And making sure that you're hanging the liter bag and you're giving them fluids. Now there are caveats to this. If someone's an ESRD patient, if someone's a heart failure patient, you don't want to overload them with fluids, causing them to go into pulmonary edema. But most of the time, if these patients are very ill in the pre-hospital setting, giving them our level of fluids is not going to harm them as it would if you were in the ER, giving them large volumes of fluids in a very quick fashion. So some hospitals that recognize EMS-initiated sepsis alerts like strokes or STEMIs and trauma alerts, it won't matter to you as the EMS provider. It's really just about the fact that you've called them in a very early fashion and letting them know that you have a very sick patient. It may actually help save their life because you explicitly communicate your concern for sepsis. Now at LSU, you call over the radio and say, I think this patient is septic. If you say that, then it starts to be just as important if you say, I have a patient that's been shot in the chest, or I have a patient with a last known well of 30 minutes ago with left-sided deficit. Early notification to the hospital will help trigger the most aggressive process in order to make sure that we can provide the patient with the best fighting chance to survive their disease process. So your heightened tone of alarm gets the attention from others and helps combat that doom that sepsis patients will have, because what's going to happen is that if you come in, you're like, yeah, the patient's sick, then it's like, okay, and then they do the labs or they get the vitals and they're like, yeah, the patient's sick, and then they get the labs and like, oh yeah, they're real sick. You got to load the boat and get everybody on board from the start. It doesn't matter if the accepting facility has a formal sepsis alert response process. Ours is still fledgling at LSU, but it's really important to communicate the abnormal vital signs just like you would in trauma. So this is just some benchmarks of what we should be doing as best practices. And your on-scene time for a septic patient should be 20 minutes. And that means that we're not going to stay on scene to hang the fluid, start the IV. You can start the IV in the back and start the fluids, making sure that you are screening for sepsis within those first critical minutes of patient encounter. And that means that our EMTs do this before the ALS unit arrives on scene, that they're asking, what's your medical history, and getting those initial set of vital signs and really getting that index of suspicion raised so that when our ALS providers come on, we can communicate effectively to those providers and make sure that, be like, yeah, this patient's real sick, they need to go to the hospital right now. And I think people would appreciate that more in letting you know that you are handing off that unstable or semi-stable patient, and we did a good job by that patient. Making sure that we alert the ER within 15 minutes of patient contact. And then making sure that with our ABCs and our other abilities like our end-tidal CO2 and glucose, that we're checking things off the box, that we're getting that 12 lead, that we're putting them on a 4 lead, that we're starting those fluids, getting the patient's temperature. If they're hypothermic, trying to warm them up. If they're hyperthermic, trying to make sure that we give them the fluid so the body naturally can decrease that temperature, treating their hypoglycemia if they have any, and knowing what our criteria are for really raising that index of suspicion. For example, QSOFA. You have a known or suspected infection, if they're tachypnic, having signs of end organ damage like altered mental status, if they're hypotensive, or even if their end-tidal CO2 is less than 25. So the QSOFA criteria, like we mentioned before, is really based on 3 things: altered mental status, tachypnea, and hypotension. If you have 2 out of the 3, they have a risk of poor outcome, and this needs to be communicated over the radio when you do patient rapport. So what about dopamine? Dopamine used to be the go-to, man. That was it. Well, dopamine was worse in terms of survival when it came to septic shock, and so it's probably better to stick with fluids and rapid transport. Now, we do have a lot of services, especially our neighboring services, that are using norepinephrine for best survival in septic shock. This is something that we could possibly bring into our system later on, but it requires you to have an IV pump or a dial-a-flow, and it has to be very specific. You have to make sure that you give the right dose for the right patient, and it is not without risks. So when you talk about the respiratory component of sepsis, we think about acute respiratory distress syndrome, and this is going to be an acute condition by bilateral pulmonary infiltrates that's going to cause severe hypoxia, and it's not because of a heart problem. It's because of an acute lung injury from diffuse alveolar injury, which, as you recall, the alveoli is the essential workhorse of the lungs, and we have many of them, and they help to exchange our oxygen and carbon dioxide. Now, there are many forms of ARDS. There can be trauma, aspiration, COVID, but severe sepsis is one of the most prominent ones, and that we are most concerned about. Now, where this comes into play is not only as important for identification purposes, but if you were to intubate somebody that's in septic shock because of airway compromise or airway protection, and also you are putting them on a ventilator, these ARDS patients require a special set of parameters that we cannot duplicate with someone who does not have ARDS, because you will cause more harm to them. So what is the main symptom of ARDS? Well, that's severe shortness of breath, and that can be within a few hours to a few days after the injury or the infection. And why is this important? Because we need to be aware that if your patient is at or below 92%, it's time to work on the airway. And that respiratory failure can happen very quickly with these patients, because as you start to, give them more relief of their symptoms with oxygen and whatnot, then they can have a catecholamine dump, or worse yet, they'll just decompensate right in front of your eyes. And so this is time that you need to be hyper vigilant of these patients' medical concerns that are right in front of you, and as they sometimes play out right in front of you. So when you start talking about that balance, the severe sepsis and septic shock, there's the oxygen consumption and oxygen delivery. And normally homeostasis is in play, where the body is balanced. Now, when you work out, you breathe faster, and the reason you breathe faster is to reduce the amount of CO2 and the amount of lactate that's generated from the muscles. Now, imagine working out, but now every part of your body is working out because of this infection. Well, the body just can't keep up with that. And so sepsis progresses to abnormalities that are going to cause imbalances of that delivery and demand, and then this proceeds to multiple organ dysfunction and eventually death. So let's talk about some sepsis pitfalls here. If someone is on beta blockers like metoprolol, carvedilol, things like that, then they can block your normal pathological response, or excuse me, physiological response to pathology, and that would be tachycardia. Altered mental status that's not recognized is, by definition, a problem because it is an end organ failure. If you don't check their temperatures, you'll never know, period. If you don't put them on end-tidal CO2 or you don't recognize the need to, you'll never know. And why that's important is we'll see in a minute. But discouragement due to a hospital's response, meaning that you say, well, I think this patient's sick, but every time I bring this patient to X hospital, they don't really take me seriously. Well, the proof is in the pudding, and if the numbers are there, then, if you have any problems, always let your supervisor know. This is just something that, we need to grow as a system. And I think that overall, our hospital systems take sepsis very seriously. And so if you were to announce, I believe this patient is septic because of X, Y, and Z, then I think that your voice will be heard. So as promised, capnography. It's a well-known tool in EMS. It provides valuable information about ventilation, but also perfusion. As long as the body is metabolizing glucose and oxygen, waste is going to be generated, and that waste is then going to be eliminated in the bloodstream, either breathing it out, like CO2, urinating it out, or defecating it out, or sweating it out. It will get out of the body in some way or fashion. Now, they can only be released in those ways. And in our body, whenever you have excess CO2, most of it, if not all of it, is released by a mechanism of bicarb and blood, but the one we're most familiar with is by exhalation. So CO2 is released in the alveoli and exhaled, and if the patient's normal perfusion of the lungs and the blood, then we're at that homeostasis. But as perfusion decreases, so does the end-tidal CO2. And this is going to result in the elevation of metabolic waste, which is primarily lactic acid. Therefore, as the end-tidal CO2 level decreases, one can assume that your elevated lactate levels. As we see the lactate levels rise in septic patients, the end-tidal CO2 level drops. So an end-tidal CO2 reading of less than 25 millimeters of mercury in the clinical setting of shock is more associated with significant increases in mortality. And patients with an end-tidal CO2 of 25 may actually have lactates as high as 6, 7, or 8. And so this is really an important tool, and capnography can be monitored and helpful in assessing whether or not therapies are improving perfusion. So remember, if you could take one thing from this slide, that mortality is higher in septic patients with elevated lactic acid and therefore low end-tidal CO2. So just to conclude here, sepsis is very serious, as we all know, and it's very important that we understand that a septic patient is an emergency, a medical emergency, and we have a very important role in recognizing that as a medical emergency and getting them to the definitive care. Making sure that you're checking temperatures on patients, very important. I know it might sound silly, but temperatures should be done on all of these patients. And if you can't get an oral temperature, then a core temperature is warranted. In addition to that, if you think it's sepsis, put them on end-tidal CO2. Monitor their end-tidal CO2. If it's low, that's a definitive finding. And making sure that we can communicate accurately and effectively with our next level of care, the nurses, the doctors, and whatnot, and saying that I am concerned that this patient is septic, and then telling them why you think they're septic, and explaining yourself to them so that you can provide a rationale. We are not robots, and we're not ambulance drivers. We are healthcare providers, and we did not go to the academy and all the years of experience that we have on the ambulance and on the fire truck and on different apparatuses. We have an important voice in patient care. In the moment that they call 911, they are our patient. So let's all be champions for these patients, and let's all communicate effectively to the team so that we can get the best possible results for these very serious patients. I thank you for your time, and please, if you'd like credit for this, answer the questions on the form that is going to be on a Google form just like last month, and I look forward to any questions you may have. Thank you.